Hello, my name is Dr. Mark Litzow. I am a professor of medicine and a member of the Division of Hematology at the Mayo Clinic in Rochester, Minnesota. And today I'm going to discuss an interesting treatment for acute lymphoblastic leukemia, blinatumomab. So blinatumomab is what we call a bispecific T-cell engaging molecule. So it's an antibody-based agent, and antibodies are proteins that our body makes that help us to fight infection. But years ago, scientists were able to make antibodies that react against the cells in our body and specifically against cancer cells. So blinatumomab takes an antibody that binds to a protein on what are called B cells. These are a type of lymphocyte, and most acute lymphoblastic leukemia cells arise from B cells. So they have this protein on the leukemia cell, and it's called CD19. We number these proteins. And so it takes the active portion of the antibody that reacts against CD19, and then through a linker, it links it to another antibody that binds to CD3. And CD3 is on a group of other types of lymphocytes that are called T cells or thymocytes. And T cells are very, very active in killing cancer cells. So basically, it's bringing a T cell right up to the leukemia cell, the B cell, the B lymphoblast, the leukemia cell, and allowing it to be killed. So it acts specifically against the leukemia cells, and it avoids some of the complications of chemotherapy. Now, blinatumomab has been around now for about 10 years, and it was first used in patients where their leukemia had undergone treatment and then come back, and it's what we call a relapse. And it was found to be effective for those patients. Many of the patients that got blinatumomab with relapsed acute lymphoblastic leukemia went back into remission when they received blinatumomab. Then it was also tested in patients who had measurable residual disease, ALL, and that is a newer concept where we now have the ability in patients that have gone through chemotherapy and gone into remission, where their leukemia, their ALL is under control. We have found that many of these patients can still have low levels of leukemia, and we call it measurable residual disease. So the leukemia is still there, but it's at a low level that in the past we weren't able to detect, but now we can detect. And we know that these patients are at higher risk to have their leukemia come back if they still have this measurable residual disease. So blinatumomab was used to treat those patients and was found to be also effective in controlling their I'll use the abbreviation MRD, measurable residual disease, where they were MRD positive. And about 80% of those patients, blinatumomab would make their leukemia become MRD negative, where we couldn't detect it. Even when patients have MRD negative ALL, we think they have a good prognosis, but some of those patients still can have a relapse of their leukemia. And so I was involved in leading a clinical trial where we added blinatumomab to chemotherapy in patients who had become MRD negative. And we gave them blinatumomab with their continued chemotherapy, or we compared it to patients that just continued on chemotherapy to keep their leukemia under control. And we found that in that setting, blinatumomab was also very effective. So the patient got chemotherapy, became MRD negative, And then we randomized them to either get blinatumomab plus chemotherapy or to continue on standard chemotherapy. And we found that after 3 years, 85% of the patients that got blinatumomab plus chemotherapy were still alive versus 68% of the patients that got chemotherapy. And this trial has had a number. It was E1910. That's the number that was assigned to the name of the protocol. And so this study showed a great benefit for blinatumomab in patients that were MRD negative, and it led the FDA to add a third indication for the use of blinatumomab. It was already approved for relapsed patients. Then it got approved for MRD positive patients. And now it has a third indication for the use, and the FDA just said in consolidation chemotherapy, but it added an indication for now MRD negative patients. And so these are some of the current uses of blinatumomab, either in relapse disease, MRD positive disease, or now in these MRD negative patients. Now, blinatumomab does have some side effects. If it's used in especially in patients that have relapse disease, it can cause something called cytokine release syndrome. And this is actually showing that it's actually working against a leukemia, but sometimes it works so well that the leukemia cells break down and they release all these proteins that can cause people to have fevers, low blood pressure, and other effects that can cause them to be quite sick. We can treat that and usually control it, but it is a known side effect of the blinatumomab. Blinatumomab also can sometimes affect our nervous system, and in particular, it can cause an alteration in people's consciousness. Sometimes it can cause people to have seizures, and so we call this neurologic toxicity. And this can even be seen in patients that are in remission and don't have a high level of disease. So this cytokine release syndrome or these neurologic side effects are two of the more common side effects that we can see with blinatumomab. Now, blinatumomab has to currently be given as an intravenous infusion, so it's pumped into the vein, and it's given continuously for 28 days or 4 weeks. That's called one cycle of blinatumomab. So typically, then patients get this 4-week treatment, then they can get 2 weeks off, and then they can get another treatment. And so patients can get several cycles of blinatumomab. If it's given intravenously, we can attach the IV bag to a pump, and so they can be an outpatient and continue their normal activities, but have the blinatumomab pumped into their vein continuously for that 28 days. Now, there is a form of blinatumomab that's being developed where it can be injected under the skin in what we call a subcutaneous injection, where that's given intermittently, initially every day for a week. And then it looks like it could be then used, say, 3 times a week in this subcutaneous injection. And the preliminary studies are looking very favorable with this use of the subcutaneous form. And so this is being currently tested in patients in a clinical trial, and it's hoped that when we have all the results from this clinical trial with the subcutaneous form, the injection under the skin, that the FDA will also approve it in that setting. So this is something that we're looking forward to in the future. And the benefit that we've seen with blinatumomab in the settings that I've already described to you have suggested to us that we can start to lessen the amount of chemotherapy that we need to give to people, and we can rely more on blinatumomab. Or there are some other immunologic treatments that are also available. And so we're looking at combining blinatumomab with some of these other agents. One example is inotuzumab. And inotuzumab is an antibody that reacts against CD22, not CD19, but CD22, which is on the leukemia cells. And inotuzumab is also an antibody, but it's linked to a chemotherapy drug. And so it's delivering this chemotherapy drug to leukemia cells. So we're looking at ways that we can potentially combine these two different treatments and lessen the use of chemotherapy. And there's already some studies in older patients with acute lymphoblastic leukemia or ALL that is showing that just giving the inotuzumab and blinatumomab and little or no chemotherapy can also be effective in treating the ALL. So this is a future development where we think that giving blinatumomab, either by itself or with these other agents that I've talked about, may allow us to lessen the amount of chemotherapy. In some instances, maybe even allow us to eliminate the use of chemotherapy. There's another subtype of ALL that has what we call the Philadelphia chromosome, or an abnormal chromosome rearrangement that used to be a very poor risk ALL, but now with the use of blinatumomab and also with some drugs that we call tyrosine kinase inhibitors, imatinib was the first one of these. There are several others. One notable one is ponatinib. There's another one called dasatinib. Combining these with blinatumomab looks to be very effective in treating this subtype of ALL that also affects the B cells, but as we call it, pH positive or BCR-ABL positive acute lymphoblastic leukemia. And so the use of blinatumomab in that setting is also looking very encouraging. So these are some of the future perspectives that we see with blinatumomab. On the one hand, reducing the amount of chemotherapy, even eliminating in some instances the use of chemotherapy, and then introducing it earlier in the course of the treatment with reduced amounts of chemotherapy to see if we can move toward getting more and more patients into remission and keeping them there and curing them of their ALL. So we're very excited about these new developments in the treatment of acute lymphoblastic leukemia. Thank you.